So today we're going to talk about the pharmacology of corticosteroids. So corticosteroids are mainly there are a class of chemicals that includes the steroid hormones that are produced in the adrenal cortex of the vertebrates, and also synthetic analogs of these hormones. So the corticosteroids are involved in a wide range of physiological processes. So we have two main groups of corticosteroids. We have the glucocorticoids, which is produced in the zona fasciculata area of the adrenal cortex, such as cortisol, which is involved in controlling carbohydrates, fat, and protein metabolism, and they also have anti-inflammatory effects. And then we have the zona glomerulosa, which produces mineralocorticoids such as aldosterone, which mainly control electrolyte and water levels by promoting sodium retention in the kidney mainly. So some of the examples of commonly used corticosteroids include hydrocortisone, and then we have prednisolone, dexamethasone, beclomethasone, budesonide, and also fluticasone. So they are used mainly to reduce inflammation, example in asthma and arthritis, and also reduce swelling in cerebral edema, to suppress the immune response in systemic lupus erythematosus, SLE. It's also used to reduce nausea and vomiting, as in cancer chemotherapy. Also used to reduce terminal pain associated with cancer, and also as replacement therapy in Addison or Addison's disease. So it's used to reduce inflammation and swelling, reduce the immune response, reduce nausea and vomiting. So it's usually used as an adjunct in the treatment of nausea and vomiting. It's not the main line for treatment of nausea and vomiting, but it can be used as an adjunct, as an additional treatment to reduce the incidence of nausea after giving drugs for the treatment of cancer. And then also reduces terminal pain, and also as a replacement therapy. So remember this 1, 2, 3, 4, 5, 6. So 6 main uses for corticosteroids. So how do corticosteroids work? So it's a drug that works by acting in the intracellular receptor. It binds to the intracellular receptor, and then you have the translocation happening, and then transcription, and then and then we have the mRNA and translation, and then finally you have the protein produced from the translation process. And then from that protein you get a cell response. So this is a bit of a delayed response. It's not something that is immediate. So this will take some time before you get a response. You need the proteins to be produced, and then from the proteins you get a cell response. So what are the gross actions of steroids? So it's diabetogenic, So it reduces the glucose uptake and utilization, and also increase gluconeogenesis. So this is quite, you could say, anti-insulin. Okay, the effects are the opposite of insulin. Insulin promotes the usage and also the storage of glucose, whereas corticosteroids they reduce the utilization and also they reduce the storage of glucose. So, and fat, so it causes redistribution and lipolysis. So there is redistribution of fat, so, and then a lipolysis followed by redistribution, and the redistribution will cause fat to be deposited in unwanted places. Okay, and then we have protein effects, causing muscle wasting, increased catabolism, and also reduce the anabolism of protein. So it will reduce the anabolism of muscle. Okay, so it breaks down protein and it doesn't encourage storage of protein. Okay, it doesn't build your muscles. And then with regards to minerals, due to the mineralocorticoid effect, okay, sodium water retention. So when there's increased sodium and water, and of course you have the increase in cardiac output, and the increase in the cardiac output will ultimately cause an increase in the blood pressure. At a cellular nuclear level, we can see the anti-inflammatory and immunosuppressive actions. So we'll see reduced number and activity of leukocytes, reduced proliferation of blood vessels, reduced activity of mononuclear cells, reduced activity of cytokine secreting cells, reduced production of cytokines. Okay, so basically you can see the reduction in the number of eosinophils, T lymphocytes. Okay, reduction in the macrophage numbers, reduction in cytokine numbers, and also reduction in the numbers of dendritic cells. Okay, so reduction in dendritic cells, reduction in cytokines, and then so this will again take some time for this effect to be seen. Okay, because of this okay, all this okay, you have to go through all of this to get the response, so it will be a delayed response. And with regards to the cyclooxygenase pathway, so we know that from arachidonic acid we have COX-1. So COX-1 is the good part, okay, the wanted effects. Okay, so you want to see the cytoprotective prostaglandins to be produced. So it's useful for platelet aggregation and gastrointestinal mucosal integrity, etc. And then you have COX-2, cyclooxygenase 2. So the cyclooxygenase 2 are the inflammatory prostaglandins. So they will produce the inflammatory prostaglandins, which leads to pain, inflammation, mitosis, and growth. So corticosteroids are said to be acting on this part, so it will inhibit the inflammatory pathway of the COX pathway. So the unwanted effects, also metabolic unwanted effects, such as growth suppression in children, okay, diabetes mellitus, muscle wasting, okay, anabolic effect. We have osteoporosis, okay, due to the catabolic effect on bone, and we have fat redistribution causing a bone-like face, okay, and also truncal adiposity. Atrophy of the skin becomes thin, okay, hirsutism, acne, so, and then development of hypertension as mentioned previously, hypokalemia. Okay, you have sodium and water retention, and then you have hypokalemia due to the mineralocorticoid effects of steroids. And then you have menstrual irregularities due to the negative feedback, the pituitary gland, and then also adrenal suppression. Okay, suppression of the adrenal gland due to the increased levels of steroids. So this is a picture of a hirsute. So other effects include infection. You might see infection, emotional disturbances such as psychosis, depression, mania, and then you can see cataract. Okay, you might see cataract. You might develop cataract due to prolonged use of steroids, glaucoma, increased intraocular pressure. Okay, it can be acute sometimes. So we also see increased incidence of GI bleeding and perforation due to the secretion of hydrochloric acid secretion. So when pepsin is stimulated to secrete hydrochloric acid, so when there is increase in that, so you might see GI bleeding and perforation. Okay, and then with regards to withdrawal, so steroids are not a kind of drug that you would like to just withdraw just like that. So you have to taper down the dose, okay, from the high dose. So maybe every week or every 2 weeks you have to go down, reduce the dose slowly, okay, if the patients are on high doses. So if not, you might get an Addisonian crisis, okay, so where you have very low level of steroids in the body, so you will be very susceptible to any changes in the temperature and physical or emotional stress. Okay, and then you have raised intracranial pressure, and also arthralgia or myalgia, and also pustular rash. So these are the relative properties of various corticosteroids, okay, when you compare them to cortisol. So you can see that cortisol has a very balanced kind of glucocorticoid to mineralocorticoid activity. So as you still remember probably that glucocorticoid activity is for carbohydrate, protein, fat metabolism, and also anti-inflammatory effects, whereas mineralocorticoid is for the sodium water retention effects. So cortisone also is quite balanced between glucocorticoid and mineralocorticoid activity. Aldosterone is mainly mineralocorticoid activity. Fludrocortisone, a higher mineralocorticoid activity compared to the glucocorticoid activity. Prednisolone is mainly glucocorticoid, so it's used a lot to reduce inflammation. Okay, and then dexamethasone is again the focus is on reducing inflammation and has zero mineralocorticoid activity. Okay, I'll see you in the next video. Thank you.